Well, good afternoon. I know it's been a long day, but it sure has been a productive day. I've enjoyed all the presentations. Commissioner Varney from Department of Mental Health and Substance Abuse Services was scheduled to be here. He is at home sick. He was trying to get here, and he's just feeling worse as the day goes on. So I'm pinch hitting, and I just saw the PowerPoint about an hour ago. So we'll see how it goes. I'm going to be talking a little bit about Prescription for Success. That is this document that's in your packet, I believe on the left-hand side in the back. And it is a statewide strategy that the department did, working in collaboration with the Department of Health, Children's Services, Safety and Homeland Security, Correction, also working with TennCare, the TBI, and the DEA. Prescription drug abuse is at epidemic proportions in Tennessee. I guess I better do this. How do you work it? I'm not sure. There. Whoops. I'm horrible with technology. Yeah. Okay. It's at epidemic proportions in Tennessee. What scares me the most, I think, is in 2012, we realized that of those folks coming into treatment from publicly funded services in our department, prescription drugs bypassed alcohol as the #1 drug of choice. And there's several treatment providers here, and they will tell you that in their treatment centers, they're seeing it over and over and over again. In a few moments, I'm going to talk a little bit about heroin. They're also seeing an increase in heroin. What we've accomplished, we've raised the public's awareness of the dangers of prescription drug and educated the medical community to be more diligent in prescribing practices. Led by the Department of Health are the prescription drug guidelines that are beginning to be used across the state on how to appropriately prescribe and treat people with pain. We've also broadly expanded the SBIRT, or the Screening and Brief Intervention and Referral to Treatment training curriculum. That is a program that we work with local doctors or health departments or clinics to do a screening and, if necessary, a brief intervention or a referral to treatment for individuals, or for everybody in the clinic, so that we're trying to get a hold of addiction issues early on, so it doesn't turn into a full-fledged addiction. We're trying to do the SBIRT across the state. Strengthen and monitoring the oversight of the opioid treatment centers. That's our methadone clinics. We rewrote the rules a couple years ago to where there's a lot more accountability, and there is expectations that people will, as soon as they can, detox people off the methadone and have them live a sober, clean life. We believe as a department that people should be abstinent, that have drug and alcohol issues, and so we've strengthened those rules. Expanded and improved the operation of recovery courts. We heard 3 wonderful speakers on the panel, the young folks that were here. Gosh, I feel so old when I say young folks, but I'm at that age where I say young folks. They did a remarkable job at speaking about their experiences. They all are graduates of the DC-4 drug court here in town. We're trying to change the concept a little bit to call them recovery courts for a couple reasons. First of all, particularly in our rural areas, it doesn't make sense to have a separate drug court, mental health court, veterans court, DUI court. You can get so many courts that you have more people coming to court than you do in the county. So we are looking at recovery courts where a judge can handle all those areas. The principles are the same no matter what type of treatment court it is. And so we are moving to recovery court. The other thing, and I think the most important thing, is we want to focus on recovery. We know that recovery happens, that treatment is effective, and that prevention works. So we want to focus on recovery, a person's positive aspect of addiction, instead of focusing just on the addiction itself. We've expanded and we've established 16 new Oxford houses. Those are houses that are self-governed, self-run, for people in early recovery to live in. It can be permanent housing, but the average length of stay is about a year, where they are getting support from other residents and from staff to live a good, sober, active life. Established a new longer-term residential recovery court that's in Morgan County. If any of you have not been to Morgan County, you need to plan a trip. It's one of the most beautiful places in this state. It's just really pretty. And we have the first, Judge Norman has a residential recovery court. We have the first statewide residential recovery court in the nation. And as I think you heard from some presentation, there's been over 80 men go through that program so far, or currently in it. We've reduced the amount of prescriptions for opioids and benzos. That has a lot to do with the work that Dr. Dreisner and Dr. Mutter has been doing with the Controlled Substance Monitoring Database. We've secured additional federal discretionary grants to address this issue. This year alone, we got about $16 million of discretionary grants, all of them focusing specifically on prescription drug abuse, mostly through the court system and through the recovery courts. We've brought awareness of the neonatal abstinence syndrome, or drug-addicted babies, and prioritized services for pregnant addicted mothers. In our system, if you meet the funding qualifications and you're pregnant, you bump ahead of everybody else on the if there's a waiting list, because the trauma, the significance of a pregnant woman abusing opioids has dire consequences many times. We've engaged 37 established community coalitions to address these issues. These are organizations in your local communities. If you're not involved with a coalition and you have one in your county, please get involved. This is where change happens, and a lot of good work has happened over the last few years. And we've established strategies to affect the number of overdose deaths. And so, challenges that we face, it's the number of people struggling with addiction in our state. There are 221 people, 221,000 people who have misused opiates or prescription drugs in the last month in Tennessee. Of those, 70,000 are addicted. We don't have the resources right now to address all of those 70,000. So the need is very great in our state. We need adequate resources for people needing treatment and rehabilitation. Alarming reports of heroin replacing prescription drugs in a number of communities across the state, and I'll speak to that in just a moment. Rapid expansion of the new pain clinics across the state. We heard some about that from the DEA this morning, and I think another speaker spoke about it as well. But huge increase in the number of pain clinics. Some pain clinics are legitimate. There is a need for board-certified pain specialists to address the pain needs that people have, but there's others that are questionable. Ensuring the proper use of all medication-assisted treatments, that's like Suboxone, methadone, Vivitrol, to help people get off drugs and alcohol a little more easily in many instances. And the cost of the criminal justice system for prosecuting incarceration and rehabilitating drug offenders, and maintain a focused collaborative effort for several years. We've got, one of the great things that you've heard several speakers talk about is the public safety sub-cabinet that Governor Haslam put together with Commissioner Gibbons chairing. We've got to continue working as departments, as state agencies, private sector, nonprofits in addressing this issue. There's not one solution, and we've got to come together, stay together in the way that we are now to address the issue. Jeez. Okay, moving forward, we want to, in the prescription for success, there are 7 goals, and these are the 7 goals there. I'm not going to read those to you. You can look at them, and you can look at more information in the executive summary that you have in your packets. If anybody wants to see the full report, there's several laying over there on that table, so feel free to pick one up when we're done. So, prescription for success, we're already seeing some impact, positive impact. In what we're doing, and as I said, it's so vital that the different state agencies work together to address this problem. Let's look a little bit about heroin. I'm going to talk a little bit about what we're seeing in state-funded treatment agencies, and David Moore, who's the chief of police for Martin, is going to talk some more about from his perspective. But we're seeing an increase, as we're seeing some slight decreases in the amount of people abusing prescription drugs, we are seeing a slight increase in the ones who are abusing heroin. That's scary, and you heard a lot about that earlier, that heroin is replacing prescription drugs. If you got a prescription drug problem, you got a heroin problem, at least coming around the corner, if not already here. While the numbers remain relatively small in Tennessee, we are seeing, as I said, a significant increase in the numbers. In FY12, fiscal year 12, our funded treatment centers provided services for 372 individuals abusing heroin. By the time we get to FY14, just this past year, we treated 685 people abusing heroin. That's a 46% increase coming into our treatment centers of people abusing heroin and addicted to heroin. That's an alarming, while the numbers are small, that's an alarming number. And very frightening. We are working hard. Several state agencies are beginning to meet to work on that issue as well. Where are these folks coming from? Primarily coming to treatment in Shelby County and Davidson County. Shelby County, of the 685 people, they had 28% just in Shelby County alone, and Davidson County had 12%. The rest of the heroin cases are scattered throughout the state. Most counties, we've had at least 1 or 2 that have come into treatment. Heroin is cheap. You heard all about that today. Prescription drugs aren't cheap. So it's an easy transition often for people. But what the difference is, one of the main differences is, with prescription drug abuse, you're about 70% of the people abusing it are getting it from friends and families. They're not going down to the corner drug dealer and getting it. They are some, but 70% is coming out of medicine cabinets. Where we, the example of the dentist giving 90 pills, I believe it was, and the person only needed 2 or 3, and then the young man got addicted. So that happens. Heroin, however, the criminal element is huge. The cartels that are shipping this stuff to Tennessee, having to go down to the street corner or to a back alley or into an abandoned house to get the heroin, you're dealing with a whole different demographic of suppliers. So I'm going to stop here and ask Chief Moore to step forward.
Well, I may be your first speaker today that doesn't have a PowerPoint, but I will be brief. A lot of what David Roush, by the way, those of you that know David Roush know that I'm not he on your schedule. David had to get back to Knoxville. He asked me, and David can't ask me to do much that I won't step in and do for him as he would me. The benefit, I think, of that is David has a shared passion for the diversion issue, drug issue, and he's in East Tennessee. I'm in West Tennessee, so I can speak to the comments as being universal across our state. So what I'll give you might have just a little bit different perspective from that of the local law enforcement. Again, a lot of the same information, but as has been said about the national issue of opiate pill epidemic, both in the state and the nation, this remains one of our biggest challenges as we see it in local law enforcement in addiction and treatment. Tightening diversion laws in Florida and Tennessee, as you heard today, as well as other states, that has had some positive impact in making it more difficult for persons to obtain or divert prescription opiates for illegal use. Another impact has been the change of pharmaceutical companies, as we heard about some of the pills that are abuse deterrent, I believe they call them, specifically where they can't be crushed or injected. The method, by the way, crushed up and liquefied, injected is the method most preferred that we're seeing in the state of Tennessee anyway by addicts. This had a slight impact, that deterrent, on the price of the drugs. Much continued work is needed along that front, as we talked about the pain clinics and so forth. But along with that, we've realized this other phenomenon which is occurring related to those positive initiatives. As strides are made to limit the pharmaceutical opiates, heroin has reemerged as a drug of choice for many already addicted to opiates. Where injectable resistant drugs have had the desired effect, those in search of injectable solutions for that habit have found a ready supply of heroin at lower prices than the diverted pharmaceuticals that they were using. The heroin in Tennessee is coming from Detroit, Chicago, Atlanta. Heroin remained prevalent in the North even as cocaine and crack rose in popularity in our state in the past few decades. Heroin has been available in Tennessee from time to time, but it was limited. The tightening supply of available pharmaceuticals has now been exploited in Tennessee. The drug supply follows our major interstates. Dealers have found Tennessee a customer-rich environment due to the pill epidemic and has made the transition easier. Some dealers have come and established residency, while others come and leave only when the product is gone. The recent trend leading to a rise in overdose deaths, as we heard earlier, is the distribution of fentanyl. Fentanyl is either mixed with heroin to increase the yield or just outright substituted for the drug. Toxicology reports on these deaths are showing the presence of fentanyl either alone or with the presence of heroin. Fentanyl emergence has also required us in law enforcement to tweak or go back and totally rewrite our policies and amend our protocols for personal protection for our personnel from the highly absorptive substance. While overall theft and burglary is trending down in the state, those two crime categories still represent the most prevalent crime activity reported in the state of Tennessee. So a few numbers. According to Tennessee Crime Online, TBI 2009 to 2013, in 2009 there were 63,000 plus burglaries and a total of over 161,000 thefts. Thefts include 8 different categories as reported to TBI. In 2013 now, there were over 51,000 reported burglaries and a total of just over 151,000 thefts. At this time in 2014, we have reported over 37,000 burglaries and 116,000 thefts. So trending down just a little bit, and I got the red X. I'm hurrying. While overall crime rates have continued in a downward trend, thefts, while down, decreased at a lower rate of decline than other categories of crimes. Couple opportunity thefts, many times associated with addictive needs of opiates, we heard that from our panel today, users, while changing the addict profile to members of households and most of our families, Reported crime does not always provide a clear picture. Reported crime does not always provide the clear picture. The likelihood of family members reporting theft by other family members diminishes dramatically in comparison non-relative reporting. I think at least 2 of the 3 panelists today indicated that they had stolen from their own families. Departments are learning of family members, victims, retrieving stolen items from pawn shops and secondhand stores without ever involving the authorities. Recent efforts in Tennessee that changed the laws in pawn shops and secondhand stores reporting have helped law enforcement identify suspects and recover property for victims. This has also made it clearer that the drug issue is what's driving the theft issue, and that's what we continue to see from a local law enforcement perspective in Tennessee.
Good afternoon. I'm Kurt Hipple. I'm the Legislative Liaison for the Department of Mental Health and Substance Abuse Services. Rod Bragg asked me to come here today and talk to you about a very exciting piece of, I guess it's a new law that's on the books. It's Public Chapter 902 of the 2014 Public Acts, if you need that reference for looking it up later on. So when the Public Safety Subcabinet began meeting, they quickly came to the conclusion that most of the people in this room already have come to that conclusion as well. That there are too many DUI repeat offenders in Tennessee. Too many people in this state drive under the influence, are arrested, convicted, and sentenced, serve their jail time, and when they get out, they drink and drive, they do drugs and drive, they drive under the influence again, are caught, and go back into the jail system. Today I'm going to talk to you about, like I said, a new law called the Recidivism Reduction Act of 2014 that hopes to target that specific issue in our state. The overarching goal of the new law is to reduce DUI recidivism by addressing the underlying reason individuals become repeat offenders in the first place, their addictions. Study after study, and as Rod said, have shown that substance abuse treatment works. And it follows that if we can get repeated DUI offenders the treatment they need to address their addiction issues, then fewer Tennesseans will abuse drugs and or alcohol. And it follows from that fewer Tennesseans will get behind the wheel of a car and drive when they're under the influence of drugs or alcohol. At the same time, we were trying to consider those goals to try to get treatment available to individuals who need it. We understood that any new law needed to reinforce the important idea that individuals who drive under the influence should face consequences for their behavior, and to participate in participation in any type of treatment program is a privilege and represents a valuable opportunity to live a better life. With these goals in mind, the Recidivism Reduction Act of 2014 was enacted. In short, this law gives a judge the power to sentence second and third time DUI offenders to substance abuse treatment as part of their condition of probation after the individual has received a clinical substance abuse assessment and served some upfront jail time. Now let's go through this piece by piece, and it's a complicated piece of legislation, but I'm going to try to break it down into 3 or 4 aspects that I think most of you are already familiar with. The first is, what is this upfront jail time that we're talking about? Well, for second-time DUI offenders, under this new law, under this new system, they would be required to serve 25 days of upfront jail time. For a third-time DUI offender, they'd be required to serve 65 days of upfront jail time. Another part of it is, you're probably thinking, what is a clinical substance abuse assessment? Well, this is a very valuable tool, and it's actually the industry standard tool that substance abuse professionals use to determine what is the appropriate amount or appropriate revenue or venue for treating substance abuse addiction issues. The assessment ensures that when someone engages in the treatment, it is tailored to their specific addiction issue. There's no longer going to be a cookie cutter approach to this. As we know, everyone in here is an individual, and everyone in here might have a different issue with a different type of addiction or a different type of substance, and that might be at a different place in their life. So whereas residential treatment might be good for me, it might not be good for someone else in this room or someone who is struggling with addiction. Using the assessment results, and this is another new part of the code, the judge would use those assessment results as a guideline for sentencing the individual to substance abuse treatment. So again, not a cookie cutter approach. It's going to be tailored. It's going to be customized. And they can send them to any number of treatment programs. They can go to a drug court, which we've already heard up here in the panel, how valuable these drug courts can be. They can send them to residential treatment. They can send them to intensive outpatient treatment. They can send them to regular outpatient. They can send them to any number of different treatment options. But what this law does that's new is it allows for several different types of jail sentence credits for those for participation and successful completion of a treatment program. For residential, it's going to stay the same as it always was under the code, day for day. You successfully complete 15 days of residential treatment, you're going to get 15 days of jail credit for that. For intensive outpatient treatment, you're going to get 1 day of treatment for what amounts to 1 week of successfully completing an intensive outpatient treatment program. Upon the successful completion of the substance abuse treatment program that the judge orders, the offender shall report to jail to serve the remainder of any mandatory period of confinement required by the law. So let's do a little math. And that's not my strong suit, it might be y'all's, but let's talk about a second-time DUI offender, someone who has a mandatory minimum of 45 days to serve. Well, under this law, they would serve 25 days up front. And let's say the judge sentenced them to what I referred to just a second ago, 15 days of residential treatment, and they successfully complete that. That's 15 days of credit. You add that 15 days of jail credit to the 25 days they've already served in the upfront jail time, that equals 40. 40 minus the mandatory minimum of 45 days in jail, that leaves you with 5 days left to serve when they complete their substance abuse treatment. Another innovative provision under this law is that a person who voluntarily attends residential treatment after arrest but prior to sentencing may receive sentence reduction credits for completion of residential treatment. We want to encourage that type of behavior, someone who sees the fault of their ways and wants to get better and goes into treatment of their own volition without a court order. We also realized that in drafting this law that we had to set up certain safeguards. That's what we talked about earlier with consequences. A judge who sentences someone to intensive outpatient treatment can also order monitoring for that person, whether it be electronic, transdermal, or GPS monitoring. They can still do all the restrictions that are available under DUI law, up to and including ignition interlock. Second and third offense DUIs, and I see the red X, thank you, allow us, usually have probation periods of 11 months and 29 days. Well, this law extends that to 2 years so that the judge can monitor just a little bit longer and make sure that person is maintaining their sobriety. And finally, and we hope it never comes to this, but if someone does not successfully complete the treatment, if they do not take advantage of this very valuable opportunity that they have been given by the state of Tennessee and the judge in their area, then they go back to jail. They do not collect $200. They do not pass go. They get no sentence reduction credits. They have to serve their full mandatory minimum plus any other time the judge wants to impose. I know I saw the red X, but I need to thank a couple of people. Tom Kimball with the District Attorneys General Conference was invaluable in this process in drafting the bill. He needs to be thanked, and we are very, very grateful to him. Several different organizations that we worked with, the administrative offices, the courts, and this is kind of my Academy Awards speech at this point, and I hear the music. The General Sessions judges, the trial court judges, the Tennessee Sheriff's Association, the chiefs of police, the Tennessee Bar Association, the Tennessee Association of Criminal Defense Attorneys, the Public Defenders Conference, Jill Talbert, who was a lobbyist for a monitoring company, course, Mothers Against Drunk Driving and Norris Skelly, who was their representative in our meetings. Tamho and Tatis were both huge in this piece of legislation. Of course, we'd like to thank Commissioner Gibbons and his team at the Department of Safety and Homeland Security and the Public Safety Subcabinet, Roger Hutto, Liz Hale, Linda Russell, Kevin Crawford, and Chris Gobble. And then finally, we'd like to thank Governor Haslam and his team. They saw the good a law like this could do in the lives of repeat DUI offenders and in their communities, and how treatment can be an effective tool in combating DUI recidivism. Thank you for your time. This has been a great event, and I hope you all have a good afternoon.
Thank you. I'm Dr. Mitch Mutter. I'm with the Department of Health and work with the substance abuse issues with overprescribing, the epidemic that we have. I was on the Board of Medical Examiners for some 12 years and chaired that board, then came to work with Commissioner Dreisner and David Reagan in the Department of Health, and I have to tell you that it's as good as it gets in working with these people, working with the governor and all of the regulatory agencies, as well as going around the state and working with concerned professional groups, physicians, osteopaths, nurses, pharmacists, physicians assistants, pharmacists. It's been a great 2.5 years, and I'm here to tell you, since I'm toward the end of this meeting and I'm on my stump, that it's as good as it gets. And when I dealt with some people, it led me to coin the expression that you never fail if you're a pessimist, because if you're a pessimist, your expectations are so low that you never fail. But I'm here to tell you that you may fail as an optimist, but you'll succeed and be much more successful. And that's what I'm saying is all of you have been through this for many years. Getting to know Joe and Greg Sullivan and Tommy Farmer and all the folks in law enforcement, it's been a great pleasure in working with you and working with such a dedicated group of people. What I'd like to go through quickly about a few things that we have accomplished, and you've heard about the safety subcabinet, so I won't delve into that, but I think a hallmark was the Prescription Safety Act of 2012. That allowed us to have the CSMD or the PMP or the PDMP, whether we gather data. And if you look at that, all pharmacies and prescribers had to register in the database. If you had a DEA as a prescriber, nurse practitioners, PAs, we have about 10,000 nurse practitioners in the state, about 5,000 have DEAs. We have about 22 physicians in the state with DEAs, and we have extenders. So we have about 38,000 registered in our database now. Many states, I just talked with Utah and Virginia this past week, they have about 10% participation in their database. So the strength of our database is that it's mandatory. They are trying to give gifts to cajole people into registering in the database. So that is an awesome piece of legislation. April 1st, 2013, it was required that if you wrote a prescription for more than 7 days, you had to query the database. And the downstream consequences of that has been enormous, and I'll go through that. The difference in our database and in the IMS commercial database, that ours is where prescriptions are filled. The IMS is where the prescription originates. We've gone from 30 days filling or reporting to the database from pharmacy or dispensers to 7 days, and in January of 2016, it'll go to what near time, not real time. My IT person says there's no such thing as real time. So anyway, we'll be there. And the other important piece of information is we have method of payment. One thing that we found through this is we can break down professionals. The number one prescriber in our database is a family practitioner, and then nurse practitioner, then internal medicine, and it moves on down the line. This is the breakdown by IMS. We have about 30 specialties. We break this down, and that data should be out at the end of this month when we start preparing the legislative report for 1 February 2015. Important thing that we're doing, though, in your specialty, when you register your specialty. So we do have data, turning data into information. People are always asking us for data, and they think they're asking for information. We got millions of bits of data, but it's not information until our epidemiologists, IT people convert it into information. One piece of information that we get is you can look on your own website or your own homepage and determine, say, I'm a cardiologist, and I can see how I rank with other cardiologists in the state of Tennessee. Say there are 5,000 family practitioners in the state, and if I'm number 50 out of 5,000, that's a wake-up call. So that is a very important piece of information. So we do have about 38,000 at the end of 2014 here registered in the database. That's not all physicians, though, because to make the database and the requirements work better, we were allowed to use extenders. So a physician in his or her office or a nurse practitioner could have a couple of extenders querying the database for them to make it more user-friendly. One of the other things we were asked to do by the legislature was to create a top 50 prescribers in morphine equivalents. We can convert all opioids into a base number of morphine. So we can convert to morphine equivalents. 1 milligram of hydrocodone is 1 milligram of morphine. One milligram of oxycodone is 1.5 times morphine. So we convert that. And so with that number, we can look at the top 50 prescribers in the state of Tennessee. And you can see there that 41 out of the top 50 are either nurse practitioners or physician's assistants. Now, all those people also were physicians because they have a supervising physician. So we sent out 127 letters to the top 50 because we had that many supervisors. Last year, in 2013, we had some 10 billion, slightly under, morphine equivalents prescribed or dispensed in the state of Tennessee. 14%, 1.4 billion, was written by the top 50. So that shows you that we need to delve into these numbers. This year, that total number is down such that it's down 12% from one year to the next. So by monitoring that, sending letters to the top 50, and opening investigations on some of those people has driven some into other areas of medicine, but some stayed and some reduced their prescribing habits, but still at a very high number, even though it's decreased 12%. So we're still working on that. This is just a conversion table we use from the CDC to get to morphine equivalents. This is a page, if we're looking up Jane Doe, you can see another enhancement we have that other states don't is automatically calculates for the prescriber when they're looking up Jane Doe to write a prescription that calculates your morphine equivalents. So it pops right up there. So this has been criticized. It's not perfect because there are a few ways that this dispensing number gets reported to the database that's not just perfect, and we're working with that. but it's highly accurate. It's not perfect. But it also allows the practitioner, knowing the conversion table that's on their profile there, to look and calculate it for themselves. They know the conversion table. So they should be aware that if it's accurate or not accurate, but most of the time it is. Another important thing we talked about earlier was doctor shopping. And this little piece of information is important because if a doctor is writing prescriptions in Nashville, Tennessee, but yet the prescription is being filled frequently in Bulls Gap, Tennessee, or Greenville, Tennessee, or Johnson City, Tennessee, that's something wrong with that. There are a few pain clinics between Nashville and Greenville, Tennessee. So the distance away from the prescriber is important information. Another thing that we do is we notify or alert or give risk modifiers is that if you have more than 4 pharmacies or more than 5 pharmacies in a 90-day period of time, or if you have 4 or 5 in a 90-day period of time of prescribers, you're also in that risk category for doctor shopping. So we might put the appropriate triangle or designation by that person's name when they're being looked up. There are many things that we can do to look at this in the future. Another thing that we will be looking at is and this is by putting gender into the database and having a reproductive age, we can notify prescribers that, hey, stop, this is a pink notification. This woman is of childbearing age and you're writing for an opioid for this person. You're placing that baby at risk for neonatal abstinence. So another notification that is out there and in place on the database. This just shows that high utilization patients, basically it's a politically correct way of saying, as you see that the PDMP or the CSMD queries increased, the incidence of doctor shopping declined. That's pretty dramatic, and we've had in the last year figures, it was something in the neighborhood of 50% decline in doctor shopping by our criteria, but 120% increase in prosecutions. So this querying the database and requiring prescribers to query that has had a great impact on the incidence of doctor shopping. It's not perfect. We got a long way to go, but we're getting there. This is just another depiction of that doctor shopping decline. And this is what I'd like to show you. If you look at the 2010 number, the 2011 number, the 2012 number, you can see that we've had a steady increase in morphine equivalents dispensed in the state of Tennessee. The 2013 number flattened. And so far this year, in comparing to those other years, we're down 3.3%. In morphine equivalents dispensed. Now, we don't know the absolute per capita incidence because the population of Tennessee is growing. I was trying to hone down on that at one time and asked the epidemiologist what our numbers were for population growth, and only could get a couple of years. And for 2010 through 12, we'd grown 150,000 in the state of Tennessee. But my epidemiologist is always proving me wrong because I gave her what I thought that meant, and it turned out it was absolutely the opposite. Of that 150,000, 80% of them were over age 55. Tennessee is a destination retirement state, so that number is changing in that regard, not as much. This just shows you we keep track of neonatal abstinence, and until we really make headway in the downstream consequences, we are not going to be successful. We do have some trends showing with both IMS data and our CSMD data showing that we are declining in morphine equivalent dispensing and consumption. But this year, I think, is ground zero for neonatal abstinence and for babies born dependent on opioids. We're at this point about 90 cases above where we were last year, and probably more due to the administrative ruling requiring reporting. We've already talked a little bit about NAS laws. I'll move on through there. I want to show you, since it was mentioned, some absolute numbers about pain clinics. We have been auditing and investigating pain clinics, and our goal is to get through all 300 pain clinics in 3 years, pretty much the rotation that Joint Commission uses for hospitals. We're finding numbers. There are 303 pain clinics in the state right now. It peaked at 333. The nadir was about 296. Our pain clinic laws aren't perfect or ideal, and this is all being discussed. This just shows you pain clinics per population. This map shows you in a remarkable way that pain clinics must have a requirement, even though not by law, to be on the interstate. So we have to have an interstate access in order to everybody have access to pain treatment. In Public Chapter 430, and that's the last thing I'll review with you, number one stated that all prescribers would have 2 hours of CME credit in pain. The other is that we would develop chronic pain guidelines. I feel very good about this. We started in January of 2013, and we have about 45 members from around the state that have participated in a very cohesive way. About 35 individuals were consistent and persistent. We had pain specialists as well as nurse practitioners, PAs, pharmacists, and the folks here at the Department of Health and other agencies that participated. We have completed those. Those have been approved by all 8 regulatory boards that have skin in the game, so to speak, and we'll be looking at the downstream consequences. The challenges we face is to increase access to quality pain management for all Tennesseans, because I think that that's one thing we overlook. We talk about the negatives of overconsumption, but the negative also is we got a group of people out there who need treatment. My family member is on pain medicine with terminal lung cancer with metastatic disease. He's breaking 5 milligrams of hydrocodone in half because he doesn't want people to think he's a junkie. But on the other hand, I had a niece who died with a drug overdose from intolerance. So there's both ends of the spectrum, and all of our lives have been hit by that sort of situation. So we do want to reduce overdose deaths. I don't think our numbers are accurate, and the CDC will tell you that because it's such a complex reporting system, but we're getting better at it. And reduce neonatal abstinence, reduce addiction, dependence, and abuse of controlled substances. Overall, though, I think that the numbers can look better, but if we still have the downstream consequences of overdose deaths and affecting our health of our state, then we're not being successful. So I think none of us will rest easy. We do want to make the CSMD more user-friendly for providers, increase access to law enforcement, and we're working on a grant for that. The use of the CDC grant we were given just at the end of last year so that we can work on identifying high-risk populations. So $1.3 million from the CDC to work with them over the next 3 years. So, and lastly but not least, is the coalitions again. I travel around the state. I've got 95,000 miles on my car over the last 3 years, and I think that visiting those coalitions is critical. They're the eyes and ears of the agencies in state government. And if we don't work with coalitions, we will fall flat on our face. And I would encourage each and every one of you to be engaged in the coalitions and increase the number. If you need to reach me about any of these topics, there's my contact information. We've only skimmed the surface. Thank you.
All right, I'm going to be different while he's bringing my PowerPoint up. Mr. Anazizi, I don't know if this is a DEA thing, but we always have to move around. When we go through training, they teach us to move around. So I guess it's to keep people awake, especially after lunch. The only thing is that I have to tell you, this is what you waited for all day. So quickly, one of the things that we've all touched on, or not everybody has touched on, but quite a few people have touched on, is the internet or the web. This is introduction to dark web. This will be very brief. The surface web and the dark web. Has everybody heard of the dark web? If I told you that we only see 5%, only 5% of the web itself is surface web. The other 95% is dark web. Now, that's not saying that everything is bad in the dark web. Part of that will just be stuff that's old, stuff that's in different formats to where we can't get to, unsearchable stuff. Every person has seen, we do it, somebody spoke about it earlier, looking at your phone, doing things, email, texting. The younger generation, that's how they communicate. It's always texting. They're not on the phone. They're not doing things. They're on different apps. They're sending email. So is that the future? The web's the future. That's how we communicate. That's where we're moving. DEA as an agency sees it more and more every day. Has anybody heard of Tor? What was Tor originally started for? Okay. Tor was started, that project, dissidents in other countries. So they could go and they could get on the web, they could communicate outside of the countries. Tor is, anybody can get on it. You can go up, you can sign up for it. Now it's slow because it's not operating off some of the bigger servers that other internet services are operating off of. So you've got a computer network. Now a lot of these are personal computers, personal networks. What they're trying to do is hide their footprint. As I said, it started out other countries using it, dissidents trying to communicate outside. Without getting into the technical aspects, like I said, I'm an agent. I've been an agent for 18 years, 26 years total law enforcement. But this is stuff that me as an agent who started out working street dope was not used to. This is something that the future generations of law enforcement are going to get more and more into. Anybody heard of Silk Road? There's been two different takedowns of Silk Road. Silk Road was a one-stop shop for different places to get anything from drugs, prostitution, anything illegal that you wanted to do. We talked about earlier, one of the people talked about Backpage. Well, same thing's going on here, but in a much larger, much more underground network. Reddit, one of the places that you can search. These are some of my favorite. Can everybody see that and read some of the different things? The dealer, selection of drugs sale, LSD, MDMA, cocaine, marijuana, and more. Drug market, anonymous marketplace for all drugs. So is this the future? Is this what we're moving towards? Google, now you just got it for the dark web, if you want to search drugs. We as law enforcement are moving towards this. Post-Snowden, you're seeing more and more companies going encrypted end-to-end. Not only for, well, it is for business, because they know that the American public is concerned about the government, other companies, knowing stuff about them. Well, through that encryption, the bigger companies are still getting your information. Who has gone to a website, searched something, gone to Amazon, search tools? The next time you go to a website, say a news organization, it just happens to pop up in the right-hand corner, the thing you searched earlier. Algorithms, they're all looking. So it's not only us, it's everybody that's looking at your information. And this is all, anybody can go to it. Bitcoin. Who's dealing with Bitcoins? Anybody dealing with this yet? Virtual currency. It's happening. To go through this in about 5 or 10 minutes, I cut my PowerPoint very short. If somebody'd like to talk about this at a more lengthy session, please feel free to contact me. I'll give you the information I have. If there's somebody or a contact that you need, please contact me and I'll get you to the right person.